Can you guys see this okay? Oops.
Yeah.
Yeah. Okay. So before I start the talk, I wanted to actually show a video of a person who has FSGS, which we will discuss. It's one of the nephrotic syndromes, and I found his story pretty remarkable. So here we go. Hopefully you guys can hear it.
He was 2 years, 4 months old, had just learned how to sleep through the night. His eyes swelled. I guess when he was 2, he weighed about 20 pounds. And over the course of 3 days, he gained approximately another 20 pounds in water weight. So then his entire body swelled. They found protein in his urine and they came back to us and they said, this is nephrotic syndrome. We treat this with pretty high doses of steroids. Dear Lord, we're going to give an adult dose of steroids to a 2-year-old. I was so scared. If you told me now that a high dose of steroids was going to be my biggest problem in life, I would sign up in a hot second.
I remember going home, getting on my bed and not wanting to get off.
And when they did his biopsy, they did find scarring on his kidneys.
Like maybe if a cat were to go inside your stomach and scratch them.
His new diagnosis is minimal change disease progressed to FSGS. And there is no cure for that.
Therefore, I take meds and meds to help the meds and meds to help those meds.
We are basically just buying time with a chemical cocktail of off-label use drugs while we wait for some genius researcher in some lab. We're in their hands. So the first time that anyone ever walked up to us and said, would you like to participate in a clinical trial? The answer is just yes, we would like to do that. In fact, can you bring us all of the clinical trials? It's years worth of work that the researchers and the physicians put into putting a clinical trial together, and it goes through so many layers of approval. By the time it's getting to a patient, there's only hope in it. And then this information from his body literally goes to these brilliant people and helps them. Like, why wouldn't you do that?
I get to help the researchers, give them my point of view from my best minutes, my worst.
Oh, sorry. I don't know why. Maybe I just don't have enough bandwidth. Hold up 1 second. Let me see if I can. Oh.
Minutes to help them discover vitamins and drugs.
Ah.
Yeah, maybe
Like,
internet.
to help cure it.
They're not going to be able to solve.
Yeah, we'll stop it for now. But, or maybe I can just make it not full screen. Sometimes that might even be better. But, oh god, my computer's like totally freezing. Sorry, guys. Anyway, kind of get the gist to think of what his story was.
His problem without information from these bodies. This is the give and the take. Like,
Okay, I'll try to stop this. Let me get out of here. So, anyways, so yeah, that was an interesting experience for that patient who has been suffering from initially minimal change disease and then FSGS. So, oh goodness, everything's freezing for me.
Yeah, I think that the video may be chopping up your audio.
Yeah. Let me also close, you know what, I'm such a massive opener. I have like all these things open. I should have done this before. Okay, so can you guys hear me okay at least?
Yeah, it's much better now.
Okay, good. Okay, so let me try to share my screen again. New share, and oh, where did it go?
We're already looking at your screen, Vinu.
Oh, I know. I'm just trying to get you guys to see my PowerPoint.
Right, it's on that. You have to sometimes you have to either like you have a Mac, right? Like
Yeah, no, I'm using my Microsoft, but actually I didn't have it. It was minimized. Let me do this again.
Got it.
After. It is not showing up. Let me do this. Let me bring this into the same Bear with me, guys. I'm almost there. Okay, here we go. So yeah, so his story was that he was initially diagnosed with minimal change disease, which is something that we tend to see, pretty high proportion in kids. They tend to do pretty well, but there are resistant cases that eventually then get diagnosed with FSGS. So we'll go over nephrotic and nephritic syndrome and discuss this further. This mnemonic was kind of fun for me because it shows the minimal change disease with a little kid, some edema, the proteinuria that the dog is licking, I guess, and then hyperlipidemia, hypoalbuminemia. And then you look at nephritic syndrome and he's got a Berger, so it's Berger's disease or IgA nephropathy, which is the most common cause. And these patients present with Coca-Cola colored urine and oliguria, hypertension. So we'll discuss some of these things. So nephrotic syndrome is diagnosed by looking at how much protein is in the urine. That's one of the things that is included. Edema is the other, as well as hypoalbuminemia. These patients also have hyperlipidemia. And so the adult range for the nephrotic proteinuria is greater than 3 to 3.5 grams per 24 hours. In kids, it's 40 milligrams per hour per meter squared. So that would give you the range of whether the person meets criteria for nephrotic syndrome. These patients tend to be fairly easy to diagnose in the pediatric arena because they have that look, which we will go over. In the adults, they have more dependent edema, but they will have the same presenting symptoms. And so you'll have minimal change disease, which we just talked about, focal segmental glomerulosclerosis, and then, which is idiopathic largely, but also has been found to have some genetic links. And then membranous nephropathy, which is a disease of older folks. And then you'll have others that are kind of put in a big basket, right? And there's primary nephrotic syndrome where we think this is the likely main cause of their kidney disease. And then you'll have secondary nephrotic syndrome where you have similar like focal segmental glomerulosclerosis, minimal change disease, membranous nephropathy, but these are related or caused by a different cause. So HIV, viruses, chronic diseases, malignancies, medications can be part of that as well. So nephrotic syndrome has, there's so many different syndromes, right? And it's related also to age. So you can see when you're first born, there's a congenital nephrosis that is a nephrotic syndrome. Minimal change occurs sometime before the age of 6. Focal glomerulosclerosis occurs before the age of 10. Diabetic nephropathy can occur anytime during those the intervening decades. Then there's a second peak for adults with minimal change disease at around 40. Then you have membranous nephropathy, which is more in your 50s, 60s. Diabetes type 2 then can come into play with nephropathy, and then amyloidosis and perineoplastic occurs in much later years. And with minimal change disease, this is a typical look, right? You have the periorbital edema, and these kids look like this can't be fun. And there's intense proteinuria that leads to intravascular depletion because it decreases that oncotic pressure, the protein that keeps your fluid in you. So as a result, these patients may actually be intravascularly depleted and have problems with hypovolemia, even though they look like they're fluid overloaded. Usually this is successfully treated with steroids. They usually have a pretty unremarkable course once the steroids help them improve. The vast majority do improve, about 80% actually do. And so that's the nice thing about this disease. And then the complications are because of this proteinuria, you lose all the good protein in your body too. And those are proteins that are important to prevent thromboembolic events and also immunoglobulin G, which would help prevent encapsulated organisms from taking over your body. So you'll have hypovolemic shock, hypertension, and then you may have complications related to DVTs or renal vein thrombosis and bacterial infections. Specifically, peritonitis is one that they discuss a lot. And proteinuria can be simply looked at. When you look at the urine, you'll see that there's this foamy cap to the urine, and that can mean that the protein is pretty high in that urine. With minimal change disease, Asians are at increased risk for MCD, and boys are twice as likely as girls to have it. And the mean age of onset in adults is about 40 years. Clinical presentation can be preceded by a URI or even an allergic reaction to a bee sting, which was quite frightening to me because if they present like that after a bee sting, I'm going to think anaphylaxis. I'm going to see that periorbital edema and worry about their airway. But interestingly, that could be a trigger for minimal change disease to then occur. And certain medications or malignancies can trigger the onset. These children have growth failure because they're not able to hold on to their protein. And then also they may have secondary causes for their minimal change disease that are related to the causes I mentioned, viruses, autoimmune diseases, diabetes. Nephrotic syndrome has a bunch of these secondary causes like I was just discussing. So, so yeah, it isn't just put into that minimal change disease primary source. There's so many other causes that can be linked to the development of this disease. So that's nephrotic syndrome in a nutshell. When that get steroid resistant, then you start to go into FSGS, which is what that little boy had in the beginning when we were watching the video. And this is actually 5 times higher in proportion in Blacks, but the video also reminds us not to just pigeonhole people into a specific diagnosis, right? Age can be less than 10 years old. Steroids can be helpful, but often it's resistant. They then move on to calcineurin inhibitors, but unfortunately that is not very helpful either. There's many other medications that they have tried, which the mom of that boy was kind of discussing as well, all of which are immunosuppressing and terrible with lots of bad side effects. And every year, half of FSGS patients who do not respond to steroids develop end-stage renal disease, and about 1,000 patients who receive a kidney transplant every year, 30 to 40% of them will develop FSGS again within hours to weeks of getting that brand new kidney. So it's a pretty devastating disease. And then the third cause of nephrotic syndrome is membranous nephropathy. This is actually more prevalent in whites. The average age is 50 years old to 70 years old, so older in their years, and it's due to deposition of immune complexes in the GBM. The secondary causes can be lupus, tumors, Hep B, syphilis, and fortunately, 1/3 of patients can complete a remission and do well in life, but 40% can develop end-stage renal disease. And there is a genetic link to this, is what they believe. So that is it for nephrotic syndrome. Now, if we look at nephritic syndrome, there's lots of different causes for nephritic syndrome, and they're both non-proliferative and proliferative. The causes of non-proliferative are, they cross over with nephrotic syndrome because all the nephrotic syndromes can also have a nephritic component to it. So it similarly has the same type of profile, but with proliferative nephritic syndrome, you have a bunch of different causes. But how we can diagnose this in the ED is mainly looking for the coca-colored urine, right? So you're gonna look for that. You're gonna look for hematuria, red blood cell casts in the urine. And then in addition, they will have hypertension, usually oliguria, proteinuria, may or may not occur. And there are different causes, again, focally. If you look under the microscope, there's focal disease where IgA nephropathy is the main one there and is the most common cause of nephritic syndrome. And then diffuse disease, which post-strep glomerulonephritis is the poster child for that one. The lupus can cross both focal and diffuse disease. IgA nephropathy is the most common cause of glomerulonephritis. It occurs in young folks. Male Asians tend to have a higher predisposition. Triggers can include URIs or UTIs before you develop it. I had a patient who actually was diagnosed with this. I noticed that his urine was Coca-Cola colored in our ED. He was 17 years old. We ended up admitting him. I did all the complement stuff and things like that that renal wanted me to do. And sure enough, they diagnosed him with IgA nephropathy after doing a renal biopsy. So the IgA deposits are in the mesangium, and it can cause years of asymptomatic hematuria. That's what he mentioned to me, that he had blood in his urine before. It appears dark and then it gets better. He was an athlete, so he just thought it was because he worked out too much. So it can happen for years before patients actually will come in and present. And then membranoproliferative glomerulonephritis is an immune complex deposition causing thickening in the mesangium and the basement membrane. It can be idiopathic. And it can be a primary disease, but usually it's a secondary cause resulting from autoimmune diseases, cancer, and infections. And this is another one that can recur in a transplanted kidney. So unfortunately, the new kidney can still develop this disease. And post-strep glomerulonephritis, which is more of the diffuse disease, commonly can occur weeks after the strep infection. It is not prevented by penicillin use. That's a board question. And it incites illness that it is usually resulting from either pharyngitis or a skin infection. So any kind of strep skin infection could still be a trigger for this to develop weeks later. C3 and CH50 levels are usually reduced. You usually do an ASO titer, which I did send off on my my IgA nephropathy patient, wondering if he might have had a strep cause for his coca-colored urine. But these patients will again develop coca-colored urine, will have hypertension, red blood cell casts in their urine. Those are the things you look for when you're thinking nephritic syndrome. And their hypertension is better treated with furosemide. And then it's important to remember with this one that there are other manifestations of this disease. So they can have HUS, they have, often they could have diffuse alveolar hemorrhage resulting from pulmonary renal syndrome, and then seizures, CNS disturbance related to PRESS syndrome, and then lupus mimicking nephritis. So it's kind of a weird one that has all these other worse manifestations. For the most part, though, these patients do fairly well and it resolves, but if it becomes an unusual presentation, that's something to consider as well. Rapidly progressive glomerulonephritis has a bunch of vasculitides under them. I know that this is probably going to bring back some traumatic memories from medical school, but this one is all about vasculitides. And so you're going to see Goodpasture's disease, Wegener's, which is now called something else. I don't even realize that they've changed names to things that I thought I knew. And then microscopic polyangiitis, polyarteritis nodosa, and then immune complex is what we already discussed with the other causes, because all the other causes can have a rapidly progressive form as well. So vasculitides result from either disease involving the GBM, so it's anti-GBM disease. You also can have HSP, and then more ANCA-associated small vessel vasculitides include Wegener's, which is now called granulomatous with polyangiitis, and then Scherk-Strauss, which is now called eosinophilic granulomatosis with polyangiitis. And then polyarteritis nodosa is another vasculitis that can cause this rapidly progressive glomerulonephritis. The way to remember Goodpasture syndrome, I think everyone kind of remembers this, but G for glomerular and P for pulmonary. So these patients tend to have hematuria and pulmonary hemorrhage. So this is going to be a pretty bad one if they come to the ED, specifically after having a hydrocarbon exposure or smoking. That can actually trigger a pretty devastating pulmonary hemorrhage. So airway is going to be your primary deal with these patients. And they can go for years without knowing that they're sick. That's a scary thing. Eosinophilic granulomatosis have these like the skin lesions that are basically granulomata on the skin. And they also have hematuria. They'll have rhinitis, runny nose all the time. And then also remember that they will have asthma for the most part, and they do have cardiac complications, specifically coronary arteritis and myocarditis. So this is my way of remembering it. It's CHERG, cardiac, huffing because of the asthma, red urine, rhinitis, and granulomas. And then Wegener's is granulomatosis with polyangiitis. This is also an ANCA positive. Anything that has like any pulmonary issue is ANCA positive. That's how I remember that. So all three of those so far are ANCA positive. These are all small vessel disease. This one is patchy necrosis. You won't, because it's patchy, it doesn't go through the entire wall of the vessels. And so you won't have infarcts per se. But with Wegener's, I remember wet because they're having hemorrhaging all over. You might have epistaxis, pulmonary hemorrhage, and then hematuria as well. So wet from blood, and then end-stage renal disease and granuloma. But you won't have asthma with this situation. It's mainly pulmonary hemorrhage, no asthma. That is different from microscopic polyangiitis, which is also ANCA positive because you do have pulmonary issues with this one too. But this one has patchy 3-layer inflammation, so the entire wall of the vessel is involved. So as a result, you have have hematuria, hemoptysis again. So that's what we see with this one. And this image shows, oh, sorry, I forgot to go over this one. Wegener's, just going back to Wegener's, I'm sorry. You do see that there's some necrosis that can happen in the face involving the nose. And that can happen with Churg-Strauss as well. And that's called a saddle deformity in Churg-Strauss, whereas Wegener's, you'll see actual holes in the nose, which is bad. And then this one with microscopic polyangiitis, you'll have something that looks kind of like erythema nodosum, but it's not really erythema nodosum. It's palpable purpura, kind of like HSP, and that usually takes over the legs, and you'll have often edema of the legs as well. And then you can have gangrene involving just the digits, usually 1 or 2 hands, but just the fingertips, not that severe. That's different with polyarteritis nodosa. Here you'll have, because it's larger vessels, medium to large vessel type, you'll have pretty bad gangrene in these patients. It's bilateral. It takes over quite a significant portion of their hands and feet. You'll have infarcts because it's involving all 3 layers of the vessels. This one has no lung involvement, so there's no pulmonary issues, and it's usually caused by Hep B, Hep C cryoglobulins, especially if you're looking at this type of gangrene, you're gonna think of cryoglobulinemia. So those are basically all of the vasculitides. I know I went through those really fast. I'll share the slides with you guys. It's not super important though, from emergency standpoint, again, to like differentiate all these ones. I just went over them because that was like the topic for today. But I think the more important thing is really trying to figure out how do we manage these patients when they come to the ER, right? Because we're just involved with being emergentologists. So even though there's lots of details that I went over, really the most important thing is remember some of these patients can come in with really devastating respiratory distress, right? So they might have bad pulmonary edema, they might have pulmonary hemorrhaging. So it's important to consider airway first, managing that early and making sure that that's not going to be the thing that holds you up with these patients. And then noticing that they have hematuria, that's going to be the telltale sign that this person has nephritic syndrome. And so then is that due to cystitis? Is that due to rhabdomyolysis? Is it due to nephrolithiasis? So considering the other causes that might result in that. And then when it comes to nephrotic syndrome, we commonly are using steroids. And then with FSGS, we're going to maybe add on calcineurin inhibitors or a bunch of other like DMARDs, kind of like rheumatologic kind of medications like rituximab, things like that. But with nephritic syndrome, you're going to think about pulmonary edema and treating that with loop diuretics and nitrates, just like you would with CHF, or if it's post-strep glomerulonephritis, using mainly the diuretics. That will help with the hypertension you see with post-strep glomerulonephritis. Consider with HSP, if you see kids that come in with all the palpable purpura on their legs and you're thinking Hinox-Schönlein purpura, consider that they may develop glomerulonephritis as well. Make sure you're checking labs on them. And then Wegener's, usually this will occur in older folks. They'll have cavitary lung lesions. So the big one to consider in this one is TB. Could they have TB instead? Or, TB is probably something you'll see more often than Wegener's, honestly. But remember, Wegener's is on that lung cavitary lesion list, and they'll present at 60, 70 years old. They'll have spontaneous pulmonary hemorrhages. That's how they might present and why you will have to manage their airway first. And then lupus nephritis, make sure to get not just nephrology involved, but rheuma involved as well, so that they can consider steroid use immediately. I think that's all I've got for you guys. Any questions? Sorry, that was really fast, I think.
Cool, thanks.